Good morning for everybody. First of all, I would like to express my special thanks to Professor Fouchard and all of the organization of Erkubai for this meeting. No? The meeting afterwards, no? The meeting after pandemic, no? A long time. No? Thank you for all the health service of all of you, no, in this very tragic and difficult time. No? Well, it's very pleasant for me to join with Professor Santos to chair this first session of the meeting. No? The main topic is if we need to do more for preventing cardiovascular disease. What are the new targets for cardiovascular disease? Not only in LDL-dependent dyslipemia, but in non-LDL-dependent dyslipemia, and in relation with new treatments, in relation with some aspects of the residual risk, for instance, inflammation. Well, it's very pleasant to introduce Professor Santos, Raúl, for the main speaker about targeting cholesterol. What is new? Thank you, Raúl.
So, very good morning, everyone. I really like to thank Professor Fouchard for inviting me to attend to this meeting and to share this session with Dr. Jesus. It's a real privilege. I was thinking when Jean-Charles invited me for this presentation, what was I going to say to an audience like this one, right? Because actually most of you have contributed a lot. Just trying to put my timer here so not to speak more than I should. Contributed to the knowledge that we have nowadays on dyslipidemia and prevention of cardiovascular disease. And it's always quite a challenge to address an audience like yours. So, but basically what I'll do is to really show what are the newest data that we have on the impact of reducing LDL cholesterol for the prevention of cardiovascular events, and what is the near future. What are we going to have very near in order to help treat our patients? So this is my conflict of interest with some companies. So basically, we all know that reducing cholesterol will prevent cardiovascular events. We know that for, I don't know, maybe 30 years almost. And actually, this meta-analysis tries to summarize most of the evidence that we have nowadays with the use of at least three types of groups of medications: statins, ezetimibe, and PCSK9 inhibitors. And as you see, it's more than 300,000 people that were enrolled in randomized clinical trials. And as you see, there's a linear relation between reduction in LDL cholesterol and reduction in the risk of major atherosclerotic cardiovascular events. So for every 1 millimole of 40 milligrams per deciliter that reduced LDL, independently of the kind of medication that we use, we will reduce the relative risk of events by around 20%. And we've learned from the trials that were made that actually even for people who already start with what we used to call low LDL cholesterol levels, so even less than 80 milligrams per deciliter or 2 millimoles per liter, if you further low LDL cholesterol, 1 millimole or 40 milligrams, we will reduce the relative risk of events by 17%. So clearly showing that the lower the LDL, the better, and so we must pursue and treat our patients adequately. Certainly the benefits of reducing LDL will be proportional to the risk, and people who are at a higher risk of events will get greater benefits, and the cost effectiveness of the therapies will be much greater. So the question is, okay, now we have PCSK9 inhibitors. We have Professor Seidar here, was one of the persons who really discovered this, and I'm really honored to present this to him. So it's really privileged to have him here. And actually, we all know that the discovery of PCSK9 really made us understand much more about the regulation of LDL cholesterol and the association of cholesterol with the risk of events. And especially for us that deal with people with familial hypercholesterolemia, the PCSK9 inhibitors really made the difference for that population. And we know that for at least 3 big trials, FUHER, Odyssey outcomes, and the SPIRE trials, that if we reduce LDL cholesterol levels with PCSK9 inhibitors, we will reduce the risk even in people already taking statins. But the question that comes is, okay, so what are the benefits of a longer-term PCSK9 inhibitors inhibition? Because those studies lasted for, let's say, 2.5 years only. And people ask, oh, maybe not be that big because it was just 15% relative reduction. So the studies were short, right? But what about longer-term impact of that? And also what about the safety of intensive reductions in cholesterol? For us, I think it's already set that the lower the better. It's okay about safety because we have long-term studies with genetic data showing that low LDL is not bad, right? But there are a lot of people that ask questions. Oh, is it safe to reduce LDL intensively? We know how the internet is and how bad for us is really try to convince our patients. And actually, we had the long-term extension of FURIER that actually the idea here was show safety, right? But they also brought data on the efficacy of intensive LDL cholesterol reduction. And you can see here for almost 6,000 people, actually, we push LDL very intensively to median levels of around 30 milligrams per deciliter. And actually, that was very safe, right? So the data that they showed us is really reassuring. And all the possible adverse events that we think that could have been caused by low cholesterol do not appear when we reduce LDL intensively. So hepatic safety, neurocognition, hemorrhagic stroke, diabetes onset. So these things don't occur because we reduce LDL intensively. And as you can see here, as time passes, there are similar rates of occurrence of these events, and they are not different from the ones that were seen when FURIER was a randomized trial, right? So this is an open label extension when everybody got evolocumab, and you see here that actually these numbers don't increase. So clearly showing that we must reduce the LDL intensity. This is follow-up for a median of 5 years, but there are people actually that were treated for more than 8 years. So clearly showing that the benefits are much greater than any possible harms that could come from that. So definitely high and very high risk people must be treated aggressively, at least when LDL cholesterol is concerned. So this is interesting because this was not randomized, right? But strongly agrees with what we know from the statin studies, the legacy of statin studies, that actually longer LDL cholesterol reductions will bring benefits and might even reduce mortality. So this is very strong data and really help us treating our patients more adequately. So the question that comes is, okay, so most of these studies actually were set in stable patients with already had coronary heart disease or very high risk people. And there's still one challenge about the intensive LDL cholesterol reduction after an acute coronary syndrome. We all know that actually the recurrence of events in the first year after an ACS is around 18 to 20%. And there's still a huge unmet need on the therapy of these patients. And the question that is asked is, should we be very aggressive reducing LDL cholesterol in these patients? We all know that actually if we give statins, we reduce LDL to a level of around maybe 60 milligrams per deciliter. We will reduce the relative risk in comparison with the higher LDL cholesterol levels by around 16%, as the PROVE-IT study showed. We have data from Odyssey outcomes showing that a more intensive LDL cholesterol reduction with litalocumab will reduce the relative risk of events by 15% in comparison with the use of statins alone. But Odyssey outcomes actually was not a pure acute coronary syndrome study because the median interval when these patients were enrolled into the trial was around 4 to 6 months. And actually know that most of the recurrence of events will be very short after the event. So this is not a pure ACS trial. And now we have evidence actually that we can be very aggressive regarding LDL cholesterol reduction with PCSK9 inhibitors immediately after an ACS. We have these two studies, EVAX, EVOPAX, clearly showing that if we add a PCSK9 inhibitor to a statin in comparison with the statin alone, we will reach, as expected, much lower LDL cholesterol levels, and we will certainly achieve the recommended LDL cholesterol goes much easier on these patients in comparison with the use of statins alone. The question that comes, okay, will we make the difference in this short period of time? We know that in the long term, if we reduce LDL intensively, we will bring greater benefits for our patients. But the question is in the short term, is it going to be good for the patient? Are we going to reduce these events? Are we going to reduce this so-called residual risk that remains despite the use of aggressive therapy with statins? We don't have the answer yet. But we have now evidence that if you reduce LDL cholesterol intensively after an ACS, you will have beneficial effects upon plaque characteristics that are associated with a greater risk of recurrence of events. So we will reduce the atheroma volume, we will reduce the amount of cholesterol in the plaque, we will increase the thickness of the fibrous cap. So strongly suggesting that if we are intensive and we give the PCSK9 inhibitor immediately after the ACS and follow these patients for a year, we will bring, in theory, we will improve the coronary plaque. But will this reduce the events? This is a very important question that is being asked. And actually, we're trying to answer that. We're participating in this trial that's called EVOLVE-MI. That's a trial that will start evolocumab immediately after an acute coronary syndrome in comparison with the use of statins alone. And the idea is really trying to show that if we are very intensive since the beginning, we will reduce the risk of events. This is a study that is being performed in 3 countries, Brazil, Sweden, and the United States, and hopefully we might come with an answer for that. That means if you're very intensive since the beginning, you will change the natural history of this disease that is really, if there's one disease that we can say that there's a residual risk, is having an acute coronary syndrome. So the other thing that I thought showing you is the advances that we had with PCSK9 inhibition for people with FH. And actually, we had many studies in adults showing that if we reduce LDL intensively, we can reduce LDL intensively with the PCSK9 inhibitor. And the question comes, so what about children, right? Is it safe to reduce LDL intensively with the PCSK9 inhibitor in kids? Are we going to jeopardize their growth, development, etc.? And actually now we have at least 3 trials, 2 that are already done, one that's going on with PCSK9 inhibitor in people, in children with familial hypercholesterolemia. I had the privilege to be the first author of one of them. That's the Hauser study we published a couple of years ago, the 24-week randomized phase of the study, showing that if we gave evolocumab to the kids in association with the statins, in comparison with statins alone, and those kids who remain with high LDLs despite the use of statins, actually, we could reduce the LDL by around 40%. And last year, we published the 2-year follow-up of these kids, everybody taking the drug, because in the beginning it was a randomized double-blind study. And it was great to show that actually we can reduce the LDL cholesterol in these kids. Actually, interesting, apparently less than we see with the adults. We had around 35% reduction in LDL, and if you go to the adult studies, it's between 50 and 60%. So maybe kids may respond less than adults regarding PCSK9 inhibition. There's another study that will be presented at the European Congress of Cardiology, hopefully showing quite similar data with alirocumab, and also we are working now on inclisiran in kids with heterozygous FH to see how they will respond to that. But the good news about this is that we can sustain LDL cholesterol reductions in the long term. Of course, there's a lot of variability on the response to the drug. As you see, there's a 35 plus minus 20-something% change in LDL cholesterol, so that depends of different aspects. But the good news is that actually not only because we can further reduce the LDL in those kids who persist with very high LDL cholesterol levels despite the use of statins, but it was apparently very safe. So we didn't have adverse events that were related to the therapy. And actually, even when we reduced LDL cholesterol intensively in those kids, we see no harm to them. So growth, sexual maturation, cognitive function, muscle, liver, and everything. So no adverse events apparently. So basically, we can really reduce the LDL cholesterol. If we need, we can use these drugs for these kids. And I hope we will have more data from alirocumab and also inclisiran in the near future. So the other thing that I was thinking about bringing you that's new is what about inclisiran, right? So the development of the monoclonal antibodies against PCSK9 was, let's say, a very quick process, and they brought us, the pharma companies brought us amazing therapies for highest risk patients. But these patients actually, they have to take one shot every 15 days or one shot once a month. And sometimes people don't like to take the injections, right? So despite the fact that they're very safe and very well tolerated. So science is advancing, and now we have inclisiran, right? Now we have a small interfering RNA that we can treat and can reduce the LDL cholesterol in our patients with 3 to 2 injections per year. So really making things much easier for the patients. Of course, one may say, oh, but if you get an adverse event, it's going to take a lot of time for the drug to be taken away from your body. That's the other side of this. But apparently, it's not like that, right? And actually, we don't know yet whether inclisiran will reduce the risk of events. Probably yes, right? Considering all the biology that we have of PCSK9, all the Mendelian randomization, the studies that we have with the monoclonals, but we still need to wait for the trials. And until there, and we know that this drug is already available in some markets, in the US, Canada, Europe, we'll have it soon in Brazil. And so what's new about that, right? So, okay, it's a drug that we know that reduced LDL by around 45 to 50%, apparently a little bit less than the monoclonals, right? And now but we must show that this is safe, right? Long-term inhibition of PCSK9 inhibitors synthesis. And this trial, I think, is Orion 3, was just published on the Lancet Diabetes Endocrinology, really showing that actually we can really have long-term reduction in LDL cholesterol when we use inclisiran. So this is data for almost 3 years of follow-up, as you can see in the upper side of the slide, that we reduced LDL, and we give one injection every 6 months after the first year, and LDL stays low, right, by around 40 to 45% in comparison with the baseline. And one interesting thing of this study, one aspect of the study, was actually they had an arm that was initially randomized to receive evolocumab, so one injection every 15 days, that reduced LDL by around 55%. And then they were switched to inclisiran after a year. And as you can see, the effects persist in the long term, right? Interesting, apparently, there's a trend to LDL cholesterol to go a little bit up when they give inclisiran, right? So apparently, the monoclonal really reduces LDL cholesterol more than the small interfering RNA, but it's not so much different. So we might have maybe 50% versus 40% in the long term. And what they really wanted to show here is that actually we can, if a patient is already taking a PCSK9 monoclonal, we could switch to the small interfering RNA in order to keep LDL low and make lives of the patients a lot easier with less injections. Of course, this will depend on the preference of the patient, the preference of the physician, but strongly suggesting that this might be an alternative for maybe moving from a monoclonal to the small interfering RNA in the future. The question that comes is, will this reduce the risk of events? We don't know yet, right? But probably yes. And this is data also that was recently published in the European Heart Journal. I know Peter and Lali are here, so they know a lot about this study, right? So this is a randomized trial, but was meant for seeing adverse events, was not meant for reduction in the risk of events, was not set for that. But suggests that actually when you compare the association of inclisiran with a statin versus a statin alone, you might reduce cardiovascular events by 26%. And these were not adjudicated events, right? So were reported events, the small number of events, but apparently things are moving on the right direction. And I was very happy because they gave me the opportunity with Viviane Rocha to write an editorial talking about this, the storybook of the PCSK9s, and that's why I'm happy to have Dr. Seydar here, because he has a lot to do with one of the chapters here. But I think that actually the book is not over yet, right? Because we still need to show that the inclisiran will reduce the risk of events, and there's more actually. There's more to come, because we also have the oral PCSK9 inhibitors coming. So this was, I think, a phase 1 to phase 2 study that apparently this oral PCSK9 inhibitor reduced LDL by 65%. There will be a presentation on the upcoming ACC Congress in March on the impact of these drugs and of this drug specifically. And of course, if people would like to better to take a pill instead of take a shot, that's an option, right? So, and hopefully these are less expensive than the other ones, because to really, I think one of the challenges is really to make people have access to this amazing therapy. So we'll see what's coming. And finally, what's new about LDL cholesterol reduction? So I guess many of you here are involved here in the clear development program. ATP citrate lyase inhibition with bempedoic acid will be an alternative or an add-on therapy to what we have nowadays to reduce the LDL cholesterol. And we were very happy to know that actually the trial was positive. So the trial was reached its primary endpoint. So this is a study with 14,000 people that were statin intolerant and received bempedoic acid in comparison with placebo. And actually the trial met its endpoint, and it will be presented at the ACC meeting next month. So of course, we're not expecting to have, let's say, a 50% reduction on the risk of events. The trial was set for a 17% relative reduction in risk, but it reminds me the old times of when we compared statins with placebo, and the first studies with pravastatin, simvastatin, but it's going to be an alternative. And I'm really very anxious to see the results. I was the leader of that study in Brazil, and certainly this will come as an alternative for our patients. So, and now to finalize, are the CETP inhibitors coming back? They're not coming to raise HDL, but they're coming to low LDL cholesterol. So we have this new drug, obicetrapib, that is very powerful in reducing LDL cholesterol, reducing non-HDL cholesterol, and reducing ApoB. So there are a lot of people investing a lot on this, and there's going to be a big clinical trial really trying to show that if we add obicetrapib to statin in comparison with the statin alone, we will reduce the risk of events. So we have seen this movie before, but we have some evidence from anacetrapib that actually, if we reduce non-HDL cholesterol with a CETP inhibitor, we reduce the risk of events. I don't know if someone may say, oh, but what about very high HDL cholesterol levels that might be induced by this drug? So I sincerely don't know, Jean-Charles. It's going to be a very interesting question to be answered by the clinical trial, right? So, but at least it takes away the bad guys from our blood, and let's wait and see for the results. So basically, that's what I had to show you. So we definitely, for this audience, I don't need to say that reducing LDL can make a lot of difference for our patients. Of course, statins can make the difference, but they're not enough in many situations. And with the development of PCSK9 inhibitors, really changed the way we do our clinical practice, and we're learning a lot more from the clinical trials that were done, the clinical trials that are going on, and we now know that if we reduce LDL very intensively, we can make a lot of difference for the higher risk people. We can treat kids with familial hypercholesterolemia now with the PCSK9 inhibitors, and I hope that the residual risk of acute coronary syndrome, at least the residual risk that is brought by still elevated inadequate LDL cholesterol levels can be reduced a lot with these newer trials, this new trial that's going on. And of course, I think Inclusional might make the difference, and hopefully we increase adherence to therapy. That is one of the biggest challenges for all of us as clinicians. And we have other therapies. So bempedoic acid is a reality. We don't know exactly the impact of it, but we'll know it soon. And hopefully the CTP inhibitors might be some good for our patients. So again, I really like to thank Jean-Charles for inviting me to present and to, I'm very grateful to him, all the support that he gave to IAS when I was president. We had many chats, and it's really a privilege to be here and to address you all. Thank you very much.